Greetings from sunny South Dakota. You might not know this, but South Dakota has over 300 sunny days a year. It might be 12 degrees outside or 20 inches of snow, but it's still sunny. I have been touting the benefits of IDF for the past 2 years. I just about tell everyone about the success we have here at Sanford. I'm excited to share the Sanford IDF implementation journey with you today. It's such an honor to be invited to speak about our process. To be honest, I volunteered. Volunteering has afforded me all kinds of unique experiences, including chairing our Infant-Driven Feeding Implementation Committee. I guess they heard about all my excitement down in St. Louis and asked me if I wanted to share our story. As Lisa said, I'm from Sanford Children's Hospital in Sioux Falls, South Dakota. Sanford Health is one of the fastest growing health systems in the country. Our system currently has 4 neonatal intensive care units. Our unit employs over 250 medical personnel and 6 neonatal therapists. There are 60 private rooms in the main unit and 12 beds in the extension unit. We began our IDF journey in 2017. Every year, for the 15 years I've worked here, we used a volume-based, practitioner-driven feeding protocol. Like many other units, the medical team decided when a baby was ready to start bottling based on a predetermined milestone. In our case, it was 34 weeks gestation. Volumes were advanced in a step-by-step fashion each day until the infant was taking an acceptable amount of their volume by bottle. After that, breastfeeding was introduced. Some babies were never able to breastfeed in the protocol. None of the preterm infants were able to start with breastfeeding. In 2017, a team of neonatal innovators determined to change that process. We did a quasi-experimental comparison of our populations before and after infant-driven feeding introduction. In 2017, we had 578 infants. In 2018, we had 526 applicable infants. Although not equal in size, there were no significant differences between the populations. During our IDF project, we used a comparative sample. We compared infants from 2017 to those of 2018. As you can see, our gestational ages were not significantly different. As it turns out, there were no significant differences between the years, except that the infants in 2018 had more ventilator-assisted days. In general, they were sicker. When considering a culture change that is going to require funding, your team must seriously consider project viability. Each health system has a set of goals that create priorities that guide all decisions, including patient care. Catering to these priorities will improve your chances for administrative and financial support. The most common health system goals include reducing waste, reducing cost, improving efficiency, improving safety, and improving the patient experience. The value equation is simple: improvements in quality plus improvements in patient experience divided by the cost. If your project supports one or more of these areas, you are more likely to receive funding. It's simple: do more with less, at the same time making the patient feel extra special. Let's hear from Christy, our NICU manager, on her reflections on the IDF implementation process from a management perspective.
Hi, I'm Christy Randall, the clinical manager in the NICU at Sanford Children's Hospital. Our unit had the opportunity to implement the infant-driven feeding program into our level 4 NICU, and we were really excited to have that opportunity. As the manager, I was responsible for ensuring that all of the staff completed that formal training and that they had the resources available to successfully implement the program. The IDF program does require a financial commitment and ongoing training for staff. I was very interested to review the impact that financial commitment had in our unit. So we recently completed a retrospective study to evaluate the impact the IDF program had on our feeding supply costs and our length of stay for each of our babies. We did note in this study that there was a significant cost savings of over $78,000 on our feeding supplies, and a significant decrease in our length of stay, over 1,850 patient days per month. It has been 2 years since we implemented this program. During this time, we did find that the program provided a framework for each of our nurses to observe and support the feeding efforts for each of their patients. The bedside nurses do continue to express an increase in their job satisfaction due to this autonomy that they are able to have for each of their patients. We are looking forward to our 3rd year of using this program and have plans to review the progress and the process towards the end of the year.
Volume-based practitioner-driven feeding was deeply ingrained in our staff. Some nurses had been using the protocol for over 15 years. Other new nurses only received education on this very protocol. Inadvertently, nurses were rewarded socially for pushing volumes regardless of the infant's participation. Changing this culture was going to be difficult. Whenever you try to change a deep-seated culture, you must engage a proven change model. The 4 disciplines of execution by Covey, Hulling, and McChesney is a well-reviewed and researched change model successful in the business environment. Many large companies have used the 4 disciplines to advance significant change and process improvement. These include Wegmans Food Markets, Swift Transportation, JetBlue, Whirlpool, the Cleveland School District, and Marriott Hotels. However, the 4 disciplines method has only recently been applied to the healthcare setting. The first most important discipline is setting your wildly important goal, known as a WIG. When you select your WIG, you must select lead measures. These are the variables that affect your goal to which the staff can actually contribute. An example of a lead measure might be completing all of the IDF education, or making sure that feeding readiness assessments are performed for every feeding. There are many variables affecting the WIG, but not all of them are affected by our action. For example, the number of micropreemies in your unit definitely affects your length of stay, which could affect your WIG, but we as a staff have no control over that. There are many lead measures to choose from when implementing IDF. We selected completion of the IDF education bundle and increasing breastfeeding participation for mothers in the unit. We also monitored 2 lag measures, decreasing the number of NG tubes used from admission to discharge and reducing patient care days. Lag measures are those variables that affect the WIG, but can only be known at the end of the process. Before any project, a wise innovator selects a wildly important goal. In their book on the 4 disciplines, the author strongly suggests that any wildly important goal be addressed to the part of the organization responsible for funding the project. At our hospital, we were asking our administration to provide over $150,000 for HealthStream licenses needed for the online portion of the education. At first, our committee wanted to write a goal about IDF or a WIG about breastfeeding in the unit. These are great goals, but they do not facilitate our administrators to open the purse strings. We needed to address health system priorities and goals, and we needed to speak their language. In the 4 disciplines of execution, they explained that a WIG is easy to write. Change X by Y in Z amount of time. Simple. Our WIG was to reduce the cost of NICU care, X, by 5%, Y, in 12 months' time, Z. This goal of reducing cost fit right into our health system's financial priorities, which included reduced cost, reduce waste, increase efficiency, and increase the patient experience. By selecting a cost savings goal, the administration was more willing to fund our project. They weren't generous, mind you, but they were willing to listen. IDF in some situations is the goal. For us, IDF was the strategy to reach our goal. We know from the literature that IDF was an effective feeding process. We knew it could affect the infant family experience, build mother confidence, improve feeding outcomes, and reduce length of stay. We knew if more babies breastfed and babies graduated from the NICU sooner, we should be able to save money on the supplies used to care for them. Let's look at this comic. It reads, as usual, the first snowfall of the season catches drivers unprepared. The husband says to his wife, throw your latte on it, maybe it will melt. Quick quiz, is pouring the latte a lead or a lag measure? It's a lead measure. You pour the coffee and some of the snow melts. You take action and a change occurs. Common lead and lag measures in the NICU might include nurses' scripted support for mothers for breastfeeding, consistently assessing readiness, appropriate application of caregiver assistance. These are all examples of lead measures. Common lag measures might include the number of infants in your unit, the gestational age of the babies, the level of illness of the babies in your care. These all affect the WIG but are not actionable by the staff. Betty, our clinical nurse educator, stated it so clearly that even the best designed protocol is unable to change culture without an exacting, proven change method in place. Let's hear what Betty has to say about change and IDF.
Hi, my name is Betty Schumacher, and I'm a clinical nurse specialist from Sanford USD Medical Center, and I want to talk to you a little bit about infant-driven feeding. My role in infant-driven feeding was part of the implementation team. Our implementation team selected a theory-based implementation approach, and we used the 4 disciplines of execution so we could have a thoughtful of implementation as possible. The thing that I like about infant-driven feeding is that it really does maximize developmental windows for babies. Those of you who have done golden hour or other thermoregulation programs are really familiar with developmental windows. When babies go through those, they wean out of isolettes at the right time, and when they don't, they don't. And so the thing that's really great about infant-driven feeding is it helps the bedside, the mom, and the team to identify those developmental windows for the baby and helps the baby move through those so they can achieve feeding ready or learn how to eat, basically. The difference it makes in my workload is I'm responsible for the follow-up afterwards. Your facility may do it a little bit different. You may identify other people, such as your PI folks, to identify lag measures and lead measures. But I look at the program and how is it going, and look at month-to-month and year-to-year statistics and see how are we doing with implementation. Are we really doing all those assessments that we need to do, and look at other measures? And so your facility may do it different, but that's how I do it as the clinical nurse specialist. And the difference that it makes for parents is really all about engagement. Parents learn the fluency of their baby's language, their feeding language, and then they're better able to interact with those babies and help those babies learn to eat. So parents who are part of infant-driven feeding, I feel, are more engaged parents, and it just makes a huge bit of difference. Thank you so much for letting me talk to you about infant-driven feeding.
Basic principles of culture change that you must keep in mind when you're introducing any type of shift, as we were. 1, get buy-in. Everyone has to be included. Take COVID, for example. We launder our positioning equipment in the commercial hospital laundry. Since COVID, our hospital-wide census has been lower. Because of this, the laundry staff have been markedly reduced. Unfortunately, our NICU census has been high for the past 4 months. Our needs have not changed. Laundry, however, did not ask NICU what our needs would be at this time, and now the NICU suffers from a daily lack of inventory. Number 2, everyone expected to perform the new process must receive the same education, and as best practice, receive it at the same time. This will reduce forgetting, or worse, wrongly remembering. 3, when getting everyone involved and everyone educated, make sure that your work group or committee includes the person in the trenches. You must include the bedside nurses if you're implementing infant-driven feeding. 4, like anyone, when something tastes good, you want more of it. When our staff were rewarded for adopting the IDF protocol, we rewarded them so they were more likely to do it. Their reward was that if they completed their education bundle in the designated time, that was reflected in their performance review. Those who didn't complete had a negative reflection in their performance review. Number 5, as everyone learns and commits at different speeds, allowing staff to question without reproach and to move to action more slowly must be allowed. And number 6, with any new process, someone has to check to be sure it's done right. This is the purpose of quality improvement work. Oh, number 7, finally, everyone must do what they commit to doing. From little tasks like making a sign-up sheet to creating PowerPoint presentations or writing articles, everyone must be held accountable. Every change process is really a roller coaster of emotions. Your staff will indeed experience these during the implementation process. Anxiety and fear, then guilt about doing the wrong thing for babies for so long, disillusionment when they can't quite get the process down, to acceptance, excitement, and finally confidence. As I mentioned at the beginning of our talk, Sanford, like so many other hospitals, followed the volume-based, practitioner-driven feeding protocol. We had extended length of stay related to feeding. We had low breastfeeding rates, which was quite dissatisfying for our families. Babies retained their NG for several days while taking their full volume, just in case they might backslide. Nurses were not allowed to progress babies based on their performance. Several factors played into our getting funding when we did. We had a change in our nursing administrative leadership. We had some unassigned funds in the foundation. The NICU director came to the initial education on the importance of IDF. We had a survey to get staff's opinion about the old feeding protocol, and we had a team of innovators to work through the process. What were our results? Our first lead measure, staff education. 100% of our staff completed the IDF education bundle in the 3-month window between October 1st, 2017 and December 31st of 2017. All of the staff completed the training at the same time. How many staff, you ask? Well, 150 nurses, 50 pediatric float nurses, 30 ICU float nurses, 6 therapists, 24 NNPs, 7 NEOs, 4 lactation consultants, and 2 administrators. That's 273 staff members completed the education. Our second lead measure was to increase breastfeeding. In the old protocol, mothers were unable to breastfeed until the baby demonstrated bottling competence. This made increasing breastfeeding easy in the unit. We were surprised, however, when breastfeeding increased to 92%. Mothers stated their desire to breastfeed at admission, participated in a 72-hour exclusive breastfeeding window. Many infants were able to discharge breastfeeding effectively for nutrition after this experience. Our first lag measure was to reduce NG use. Our materials management tech completed a cost comparison of NG tubes from 2017 to 2018. I'm excited to share with you that our unit saved over $78,000 in 2018 from decreased NG use. Sure, you might be thinking that our population in 2018 was different from the one in 2017. But as you recall, after breaking down the sample size for each gestational age, there were no significant differences, except for the 2018 babies had more ventilator days, which meant they were sicker, which you would expect to then need their NG tubes longer. And that was not the case with infant-driven feeding. Our second lag measure was to reduce the length of stay. Our length of stay was reduced by an average of 14 days, with a range of 2 to 21 days. Another way of looking at length of stay is to compare patient care days. How many patients are cared for in your unit each day? In 2018, our patient care days were reduced by over 1,800 days. Because of this length of stay change, our medical team had to change the model with which they serve the patients. Who are these innovators? Innovator is a personality trait we sought out while seeking representation from all the stakeholders. Of course, we had speech therapy, lactation, we had a physician, an NNP, we had bedside nursing, but we also included the electronic medical record staff and the administration. You can't talk about using staff time without the purse holder present. So having an administrator on your committee is vitally important. For us, it was important that the leader of the committee have powerful, consistent organizing skills, motivation skills, and communication skills. There are many moving parts and people completing tasks. Without good organization, the project can fall into silos. Your leader and your administrator must ensure a cadence of change. Meetings must be held, time reserved, assignments completed. Finally, don't be afraid to add a naysayer or a late adopter to your committee. They have great insight and points of view that will allow you to capture the entire staff, not just the yes people.
I'm Susie Ruder. I'm an attending neonatologist at Sanford Children's Hospital, and I work in the NICU.
Dr. Ruder, did you have any familiarity with infant-driven feeding prior to when we started it in 2017?
You know, I think that I had heard from a couple of our nurse practitioners that had moonlighted at our facility, and they had thought we were a little outdated by not being on the IDF protocol. So that's really the only exposure I had had to it prior to the implementation.
Did you participate in any of the educational opportunities that were provided when the unit started the project?
I don't think I did. Mm-mm.
Did you watch the little introductory video, that one?
That I did.
Okay.
Yep.
Okay. That's meant for MDs.
Yeah.
Okay, since the implementation of infant-driven feeding, can you express some of the changes you've seen in the unit or with the babies or with the families?
Well, I've actually noticed several things since the implementation, and first and foremost, it has gotten babies out of here faster, because babies are doing their own thing and we're allowing them to do their own thing. I think so many times I can remember when we would make rounds, we would say, oh, should we go to 5 cc's today? Should we go to 10 cc's? And the parents weren't necessarily suspicious of us as a medical team, but we were, as a medical team, we're not there for feeds. So here we come around, you know, for 10 or 15 minutes a day, and we make a plan that could potentially impact how long that child stays in the hospital. And really, it wasn't good decision making. So this way, the babies know what they can take. If they're not ready to feed, they're not going to feed. If they want to take a full bottle, they'll take a full bottle. And I think it's very beneficial also for the parents to see that, because then the parents know that it's up to the kid, it's not up to the medical team. And that helps create credibility for us, but also for what we're doing as a unit. And I think it's also getting kids out of here faster. We definitely have a decreased length of stay because these kids are telling us what they can do, and we're allowing them to show us what they can do.
Do you think families are happier with IDF?
Absolutely. You know, families that had babies in the NICU with the old feeding protocol, and now they've had babies in the NICU with the newer feeding protocol, and they're just thrilled. They're so satisfied that we've changed to this method, and yeah, I think they're very satisfied with the change.
Thank you. Could you speak to the orders, like how ordering feedings have changed since the old program where we did volume driven, and now we're into IDF? Does it seem out of control?
No, I mean, I think it's pretty straightforward. I think initially people were a little confused about, okay, so when you do the breastfeeding, how do we do that? And then how do you calculate? But I think that's going to be true for any new protocol that you use. Now I think it just goes over without really a hitch. I mean, when the scoring is adequate and it's very specific about what scores you have to get to start infant-driven feeding, and we all know that, and then when you click the button that says IDF, it's really up to the child when the child's feeding scores are low enough.
Thank you. You made me think of something about those scores. How important is it for you as a medical practitioner to see those scores, and how reliable they need to be?
I think it's critical, actually, because it really depends on whether you even give the baby the chance to show us what they can do with the feeds. So I rely on them 100%, and I think that our families do too, because they recognize the expertise that our nurses have, since our nurses are the ones that are assigning the scores, and they're going off of the algorithm for scoring. But it just goes to show that when you've seen a baby that gets a high score, which, as you know, is not a good score when it comes to feeding, these babies don't do well with their feeds. And so when the parents can see that, they know, they get it, they understand why the feeding isn't successful, because the score isn't successful.
People have asked, how do you get the MDs on board with infant-driven feeding? Was there anything about the information you received, the articles you read, the in-servicing, the posters, that really helped you as an MD and our whole MD team to get on board with IDF?
Well, I think the video that I watched helped me to realize that, okay, this is a new way of doing it. And I think we were all hungry for a new way to do it, to be honest with you. I think that was probably the most important thing, was when you get to a point where you're like, okay, I feel like this just doesn't feel right. Should we go to 5 cc's BID? And parents weren't satisfied, medical team wasn't satisfied. So I think that we were excited for something new, and I think that's probably the most important initial step. And then the fact that we were seeing success with it, families were happy, nurses were happy. I think it just all kind of flowed together, and because I didn't partake in a lot of additional education, I really wanted to see what it did clinically, and I was convinced clinically, because really that's, even if you look at all this research and you read all these papers and it's convincing on paper, if you don't experience that in practice, honestly, in my eyes, it doesn't matter, because you have to see it happen before you, and it's your families who you're accountable to. So that's the most important thing.
Thank you, Dr. Ruder.
As you can see, we started our process in 2017. It took 6 months to get administrative buy-in and find funding. We released the education bundle in October, and go live was January 10th of 2018. We implemented and supported education throughout the year of 2018. In 2019, we began to analyze the changes noted, and now in 2020, we are creating a refresher education and publishing an article on our process. Luckily for us, we don't actually have to invent the wheel of refresher education, as Dr. Brown's Medical is putting together a program to help people who have adopted IDF to refresh the education for their staff. Let's listen to Megan, a staff nurse, as she expresses her impression of infant-driven feeding.
Hi, I'm Megan, and I am a nurse and RN here in the NICU at Sanford. We began IDF, which is infant-driven feeding, I don't know, maybe a year ago or so. And I have really enjoyed this process as we began it, mostly because it's given us nurses and parents more freedom to read our babies' cues, and I feel like it's allowed the babies to even get out of the NICU faster, since we're not limiting them so much as to how much we allow them to bottle, and we're just reading their cues and letting them tell us what they're ready to bottle. And the training was really pretty simple for this. We just did a couple Sanford learns and then paid attention to the emails and things that they sent out about it. And then if we ever had any questions, our speech therapists were always available to help us out. So I think overall it's been a great experience, and I hope we continue with it.
Education begins early. You have to educate your financial backer. You have to educate the administration about the efficacy of IDF and how it can be implemented efficiently and effectively. We saturated our staff with education. It was literally everywhere. Every week, new information, reminders, questions with answers were posted where staff could see them. Everyone was talking about IDF. We had a question and concern box where anonymous questions could be left. These questions were then answered at staff meetings for all of the staff to hear. The implementation team and all the speech therapists were present at the bedside, roaming room to room, offering support for interventions as well as documentation. Charts were reviewed for completion of the IDF flow sheet. Huddle reports shared information from shift to shift on what each baby needed for a successful feeding. And finally, the online education has been integrated into our new staff orientation. Anticipation builds excitement. Before we released any education, we left hints around the unit to get staff thinking about finally being able to advance babies, to finally know what makes baby a good feeder, and have the possibility of introducing breastfeeding at an earlier versus later age. These little enticers were effective in getting staff excited for the education bundle. How many times can you say that your coworkers were excited to complete 4 hours of online education while they were working? That was only part of the education bundle that staff completed. Once education was released, and throughout 2018, we posted reminders, explanations, ideas. These changed monthly and as needed. These are photos of some of the signs that were placed in the bathrooms and in the lounge for staff to remind themselves of what was the right thing to do. Carrie is one of our NICU speech therapists. In our unit, speech therapy complete all of the feeding evaluations and nipple recommendations. Carrie shares her impression of IDF with us.
Hi, I'm Carrie Hartzel, and I'm a speech therapist here at Sanford Children's Hospital and in the NICU. I was able to complete the same IDF training that all of our therapists and NICU nurses here were able to do, so that was really helpful that we're all on the same page. What is the best effect of IDF implementation? What I really like about this program is that the babies are in charge. They get to show us or tell us how much they can do. And I feel that it really gives us good data or information on what they're able to bottle, and we can go back and look at their trends for feeding, and in the end I feel like it helps us guide their feeding journey a little bit better. What difference does IDF make? I feel like there's less pressure as a speech therapist to fix a baby, and I feel like it helps us understand their cues so much better. I also feel that it helps us create better relationships with parents and their babies, but also between the parents and us as therapists. And in the end, it's so much more helpful for the babies because we're understanding what they're trying to tell us. And I think it's just been so helpful for us, for the parents, and for the babies all together. I also like that IDF takes the pressure off the parents being so focused on a number or a volume for feeding. and that they, instead of them saying, I got my baby to take this much, I'm seeing a little bit of a change or a trend towards my baby took this much, and our feedings are becoming so much more focused on quality feedings instead of looking at that number or that volume. So overall, I do feel like in our NICU we're seeing a little bit of change, focusing on what the babies can do and not so much what the therapists or the parents or doctors are doing for the babies.
For your reference, I have included the various education tools that we used. There are several aspects of implementation that did not exist in the old format. These included a family feeding plan, a nurse resource binder, an NTMTC resource sheet, electronic medical record changes, a flip book for references, and a parent education handout. Parent feeding goals. Wow. We never asked parents what their feeding goals were before we implemented infant-driven feeding. To help staff build a habit of asking parents what their goals for their baby were, we had these little write-on, wipe-off sheets that hung near the nurse's documentation station. They would simply fill them out after conversing with the parent, and then if a parent changed their mind, they could just wipe it off and write the new information in place. These were hung where all nurses could see them and have easy access. Nurse, practitioner, and physicians used an IDF reference sheet. Their sheets were laminated and hung on all of the portable computers they used during rounding. As nurses were learning the language of IDF, a resource sheet was created for them that had the scales in ready view. The electronic medical record had to be changed. The old feeding order set and the old feeding flow sheet were removed at Go Live. I have an example of the new system here to show you. The medical team now had 4 choices for feeding orders. As you can see, an infant could be NPO on the nutritional protocol, which always used an NG or an OG. They could be IDF with their prescribed volume, or they could be IDF, ad-lib demand, no NG. The MD simply clicked on the box for the order they wanted to occur. These orders appear in the nursing Cardex according to what food, what amount of food, whether it's ad-lib or prescribed volume, the longest time between feeds, frequency of breastfeeding, nipple or bottle. If any other feeding program aside from IDF was to be used, the practitioner had to type it in letter by letter exactly what they wanted. The feeding flow sheet looks like this. This is a completed one for you to review. Our EMR is also set up to summarize the feedings each day and each week. This allows the practitioner to see the trend over 24 hours up to 7 days. Take a look. There's readiness cues, quality scores, caregiver assistance, the duration of the feeding, ordered feeding volume, the volume taken, the percent of their total volume taken, the nipple used, the duration of breastfeeding, events that may have occurred during feeding, and the number of events, the feeding method, a special bottle if used. We have since eliminated the rows that include bottle reasoning, bottled breast milk, and feeding method. These are the IDF Flip Cards. As you can see, they were simple cardstock cards with pictures and graphs on them that used a little jump ring and could hang from the crib, isolette, or from the cabinet in the room. A treasured and highly effective tool for us was the creation of these reference cards. Ours had the scales, but also problem-solving strategies, and more importantly, what not to do. The flip cards are shared with parents, family members, and float nurses. Parent education was necessary with IDF. A generic parent handout was created that explained the process, educated them on readiness and weight cues, and offered general interventions such as elevated sideline and pacing. Parents are provided with this educational handout at 32 when their babies are 32 weeks gestation. Other strategies employed included augmented pre-shift huddle discussions. At Huddle, on each shift, staff were trained to review the feeding order, the support the baby generally needed, and the cues the infant demonstrated. This allowed the next nurse and her buddy, who may end up doing the feeding, to be informed about each infant and their care. Huddle occurs at every shift. One of the principles discussed in the 4 Disciplines book is to celebrate milestones. We had many celebrations. We had treats, pizza, stickers, awards for completing education. We had a party for education release. We had a party at Go Live. We had a party for the first baby who went home after IDF was implemented. We had a party for the first micro preemie who went home breastfeeding. We had an IDF anniversary party. We had a change in length of stay and money saved party. Lots of parties to reinforce behavior for our staff. You might be thinking, what good initial results we had, but did we keep it going? Is it still IDF in our unit, or have the staff backslid into some old habits? Just like my yoga teacher keeps having to remind me not to hold my breath when I'm stretching, policing change is a necessity. We keep the staff on track with one-to-one bedside education in the moment. We review feeding performance each week at interdisciplinary rounds. We include education for the residents. Old staff preceptor new staff on the use of the scales and the interventions. Unexpectedly, removal of the old order has proven highly effective for IDF stability. We added speech therapy time. We placed Dr. Brown preemie nipples on the supply cart for staff to grab when they needed them. And finally, our speech therapy team reviews each baby's feeding performance through the IDF flow sheet on a daily basis. The process of implementing IDF was intense, serious, and consuming. With all of this work, though, we experienced amazing results. We were able to cover all the costs of training with the money saved by short length of stay. We were able to save the unit 20% on feeding costs. Parents have expressed greater satisfaction with the process, and 92% of our mothers who express a desire to breastfeed are able to do so. Staff engagement is improved, as is coordination of care. Nurses are offering feeding information at rounds, and this spills over into taking ownership over what's happening with the baby and sharing about pain and respiratory effort and digestion. There have been some frequently asked questions when people have heard about our results. Do we really get the results I talked about? Are these changes still in effect? How did you get the MDs on board? How much did it really cost? And is all this preparation really necessary? So, did we get the results I talked about? Yes, we did. 100% of our staff were trained in the 3-month education window. We reduced the cost of NICU feeding equipment, our goal 5%, but we actually reduced it by 20%. More mothers participated in breastfeeding, up to 92%. We recouped the costs of the HealthStream online education, and we reduced the length of stay and patient care days. Are we still experiencing these results today? Yes, we are. Every new staff member completes training in the program. Just last week, we discharged a baby born at 27 weeks and 3 days, breastfeeding 4 times a day and bottling the other 4 times a day with a Dr. Brown newborn nipple at 36 weeks and 1 day. Tomorrow, we are sending home a baby born at 26 weeks who is bottling all of her feeds, and she's only 36 weeks and 3 days. How did we get our physicians on board? First of all, we shared the literature review about the effectiveness of infant-driven feeding, and we summarized all the results. We didn't ask our physician to read all those articles, but we did create kind of a meta-analysis of the articles and the results and made the articles available to them if they wanted to read them. We had physicians as part of our committee, and they were held accountable to do the work that they committed to doing. Finally, you got to show them the money. Show the physicians the amount of money they can save the unit by implementing IDF. And finally, simplify the ordering and infant performance review. Make the information that IDF provides them as easy to read and as quick to access as possible. How much did it really cost? Well, here we go. The staff completed the 4-hour health stream education during their work hours, and they also had to complete 1-hour quarterly IDF education presentations for a total of 4 hours. There were 250 health stream licenses purchased. There are 4 hours of staff time for over 200 staff members, and there are untold hours of committee time. But happy families feeding their babies is priceless. Is all this preparation really necessary? You bet it is. Indeed, all this preparation is necessary. To change culture, a proven change method, elbow grease, persistence, and accountability are all a must. We have reviewed the key points already, and I'm sure you understand the slide, but I wanted to mention one more key point. When we implemented IDF, we did not have any other initiatives started. We did not get new pumps. We did not get new ventilators. We did not change our positioning equipment. We didn't change our nurse staffing patterns. When you're asking a staff to make a paradigm shift of this magnitude, you really have to keep them engaged and focused on the change at hand. Thank you for the opportunity to share our process of implementing such a paradigm shift to IDF. I appreciate your time and attention. Good luck as you seek to improve the feeding process in your unit.
We do have some time for questions. So I just want to remind everyone that if you have a question, to go ahead and type it into the question box on your keyboard. And the first question we have is, Elizabeth, if you could answer, how did you incorporate breast with bottle feeding? I'm not sure specifically, but if you want to maybe just address, how that, I know that for a lot of hospitals, that's usually one of the biggest difficulties is how to work with that with IDF. So if you have any key points for that, it'd be great.
Sure, I'd love to answer that question, Lisa. Here at Sanford, we introduce oral feeding using a 72-hour exclusive breastfeeding window or opportunity. So mothers who've expressed their desire to breastfeed are offered to participate in a 72-hour reserved breastfeeding only feeding experience. So they commit to being present in the unit, and whenever their infant is queuing to eat, then they're allowed to go to the breast, and no bottles are introduced during that time period. After the 72 hours is completed, or if a parent chooses to introduce the bottle before that, the bottle's introduced, and then our nutrition team determines how many bottle feedings with the fortified breast milk are necessary for growth versus how many times the baby can take food from the breast. So usually that's a half and half breastfeeding, half bottle feeding, but sometimes it's 60-40 where there's more bottle feedings, and sometimes it's the opposite where there's more breastfeeding.
Great, thank you. And I just also wanted to, for those of you who aren't familiar, so the protocol for infant-driven feeding does recommend a protected breastfeeding window. It doesn't specifically recommend how many hours or days, and leaves that up for your hospital, because some hospitals could be a very long time, but realistically some might not be willing to do 72. So we really leave that period up to you, but it is essential that you have at least some type of protected breastfeeding window. Well, let's finish up. Somebody else asked, how do you manage the 72-hour exclusivity with moms who are on MAG? Can you answer that question at all?
I would say in our unit, if our moms are still on MAG, they're not coming into the unit yet. So those babies would be fed via NG, and they wouldn't be offered a bottle until their mom could be present in the unit.
Thank you. And what about, this is a question, I'm going to give it to you, but then I'll probably need to finish up because It's about the specific. Well, you know what, we're going to finish on this. People want to talk about the breastfeeding. I knew this because, right, this is one of our biggest challenges. So as the questions keep rolling in on breastfeeding, let's address them. When you use the 72-hour breastfeeding window, did you do pre and post weight?
We use, as suggested by IDF, we use a time algorithm we assess the amount of time the baby's active at the breast, and we use a mathematical formula to determine about how much feeding that would be. For instance, if a baby's active at the breast for less than 10 minutes, they get an entire NG feed. If they're active at the breast for more than 15 minutes, then they get only 1/4 of their NG feed. We can do the weigh in and weigh out if we feel like we're not getting a good satiation from the infant. So we can do both, but generally we just do the timed algorithm.
Yes, and for clarification, for those of you, there is a breastfeeding algorithm that does come with the infant-driven feeding program, and it's what Elizabeth referred to it, but you actually have access to that when your unit purchases the infant-driven feeding program. All right, how about, there's one up here about how, and this is the one I might have to piggyback off on, but how were the teaching modules standardized and provided to staff, purchased by vendor, done so by hospital system? And that, you can add on, but Elizabeth, but for this specific question, for those of you who maybe aren't familiar with the actual infant-driven feeding program, it is a program that your hospital may purchase, and it is an online teaching program that your hospital does purchase through Dr. Brown's Medical and infant-driven feeding. And then you have access to the program and load all of your, for example, all of your staff, and they all take the same exact program. And that is really one of the beautiful things about IDF is everyone is getting the same exact education, as opposed to, only 10 people kind of doing super users, but everyone gets the same exact education, and we can have much more consistency on the unit. Do you want to add anything to that, how that worked for you guys?
Sure, Lisa. I just want to add a comment that the education that's provided in the modules by Dr. Brown's is so in-depth. It talks about admission, developmental support from admission all the way through discharge. It's unlike other education I've experienced where you only talk about the cues or the caregiver strategies. It really talks about how feeding develops with those very first oral experiences way before a baby's put to the breast or put to the bottle. And I think having all of our staff understanding that was definitely a key to our success.
Thank you. There's another breastfeeding question. How do you allow protected breastfeeding window with parents who are not present 72 hours, such as a mom who can only visit 1 to 2 times per day, but infant is still showing cues?
Okay, if a parent selects the 72-hour breastfeeding window, they can select actually how much time of that they want to be present. So if they can only be present twice a day, then we might only offer them less than 72 hours. We might want to get them to commit to 1 full day or 2 for 24 hours or 48 hours. If they can only commit to certain times of the day, it makes that very, very difficult. And we explain that to parents that we're only going to feed their baby when the baby is cueing, which means they might come when the baby's not cueing. It presents a bit of a problem, but we just have parents pump, and we offer, NG and bottle if the parents want to bottle. That usually prompts parents to close the breastfeeding window earlier.
Thank you. And I think that your hospital, you presented a slide earlier, but your hospital, people, we tend to think this is going to be really, really hard, but once you get these parents on board with it, they really want to do this. And your statistics of how many parents actually participated in that protected breastfeeding window are amazing. It was in the 90-some%, correct?
Yes. Mm-hmm.
So parents get on board with it. And again, like Elizabeth said, it can be altered, and it doesn't have to be 72 hours, but you can adjust that according to what your population looks like. If I did a literature review on IDF like you did, would it be convincing enough to engage interest in my physicians? The majority of them are all currently volume driven.
I would say it certainly would. If you provided them information on the outcomes of volume-based, practitioner-driven programs, which there are very few studies that are actually looking at that protocol, versus IDF, versus maybe just simple cue-based feeding. You'd be able to demonstrate that IDF has a greater depth as well as volume of literature and research surrounding it.
Yeah, and I just also wanted to add that for those of you that do have questions about literature and research for that, we can, if you contact us, we can help you with that, because we do have a large, you know, a reference list about articles to support infant-driven feeding. And we have research-based articles, but yet we also have compiled, there have been in the past 2 years, when you go to conferences and people who are doing QI projects and posters, and now we have several of those hospitals, including yourself, Elizabeth, who presented the data and the quality improvement projects that are changing because people are implementing infant-driven feeding. All right, let's take one more question and then we'll have to end. And by the way, if you do have more questions, we will have Elizabeth answer them, and the answers to the questions and all the handouts will be posted along with the webinar in a couple of weeks. But here's the last question. How did you change the mindset of the more experienced or older NICU nurses who are also volume driven?
We invited our biggest critic to be part of the committee. So as committee members, we read all that literature. So there's no denying it. When you read the literature, there's no denying that infant-driven feeding is the best way to feed infants, premature infants. So as part of the committee, she had to read the literature as well, and that was a huge step in moving her forward. And then making it so nurse-driven and nurse-friendly that really helped also get our naysayers to buy into the program.
Yes, I love that. I love that concept of the naysayers, and you definitely have to have them on your team. You can't just have all the people who believe in it. You have to get those nurses who are kind of poo-pooing. And so I want to just thank you again, Elizabeth. This is so helpful, and I know people will continue to have questions. If those of you who do have questions about infant-driven feeding and want to get a hold of Dr. Brown's, you can contact medinfo@drbrownsmedical.com, and we can give you reference articles, but you can also just let us know you want to chat with someone. And every area of the country has a specific advisor for IDF for your particular part of the country, and we can get on a call or send you any information that you need. So that's medinfo@drbrownsmedical.com. All right, well, that wraps up today. I just want to thank Elizabeth and all of our attendees. Our next webinar will be at the end of August by Dr. Caitlin McGrattan. Get ready to get your science on, because on August 18th, Dr. McGrattan will present A Field of Gray, exploring the evidence to guide infant dysphagia clinicians through the most common clinical conundrums. Please keep on the lookout for the announcement or go to the Dr. Brown's Medical website to register. Thanks so much, everyone, and have a great day.